extensive electrode portfolio of any manufacturer, and we also have a unique software called OAT Plan. This allows the surgeon to select the optimal length of the electrode array for each individual. And this is actually one of the reasons that MED-EL was the only FDA-approved cochlear implant for single-sided deafness. Full coverage of the cochlea with that electrode array is really important for people with single-sided deafness because we want those. We want that sound to match as naturally as possible to the other ear. Important factors to consider when you are counselling a person with single-sided deafness. Really important to first up identify that they are a candidate for single-sided deafness before you go for a cochlear implant for single-sided deafness before you go too much into the counselling. So confirm that candidacy first and then discuss realistic expectations. So what you expect in the way of binaural benefits, what they can expect in the way of relief from tinnitus, managing expectations before implant about a commitment to rehabilitation. Rehabilitation for people with single-sided deafness using a cochlear implant is more critical than a person with a bilateral hearing loss. So maintaining that motivation to commit to the rehabilitation is really important. Discussing alternatives is also important. We want candidates to be well informed when they're making their decision. So most adults will have tried a hearing aid solution, so a CROS aid, contralateral routing of signal hearing aid, where the sound is picked up on the deaf side, routed across to a hearing aid in the good ear. If they haven't tried that, it's certainly worth discussing that. One of the limitations, of course, is that there is no binaural hearing effect. And this is the same for any bone conduction solution as well. So MED-EL offers the Adhear and the Bonebridge as solutions for single-sided deafness. They are good solutions for people who a cochlear implant is not a possibility for. Neither, however, will provide a binaural hearing solution. There is some evidence that a Bonebridge does suppress tinnitus a little bit, but not as effectively as a cochlear implant. So why do people choose a cochlear implant for single-sided deafness? I thought I would share with you a testimonial from Mary Jane. Mary Jane is one of our peer mentors in Australia, and she lost her hearing at the age of 59 from MED-EL disease. It was a very sudden and dramatic drop. And she said she chose a cochlear implant because her ENT surgeon couldn't tell her if the MED-ELs would develop in her other ear. So she felt the cochlear implant was insurance for her against hearing loss in her other ear. Ended up being a good decision for her because now, about 5 years later, she has lost the hearing in her other ear, but her cochlear implant is up and running. So she's not fine with losing the hearing of the other ear, obviously, that's bad. But the good thing is she had hearing established with her cochlear implant. What about from a parent's perspective, making that decision for their children? So this is the story of Valentine. You can read his story on the MED-EL blog. He struggled. It's quite an interesting story because his hearing loss went undiagnosed for many years because the hearing tests that he went for were delivered binaurally. So he was not diagnosed until he was about 6. Then his parents made the decision to get a cochlear implant. He was really struggling at school, and they said that they were full of confidence and anticipation about what the implant could provide for him. So let's now look at activation. So this varies depending on where you are in Australia. It can be actually next day or up to 2 weeks, maybe 4 weeks, depending on where the person lives, if they have to come back for the surgery for their switch on. And here's some recommendations for the audiologists. As said, not an audiologist, but we, similar to a person with bilateral hearing loss, suggesting a low stimulation level to begin with, but very quickly moving it up to levels where the recipient is going to value that input. Some considerations for fitting. Audiologists focusing on binaural comfort. We don't want the cochlear implant to dominate. We need time for that central adaptation to occur, and that's going to be part of your counselling. So managing those expectations, understanding speech initially needs to be, that expectation needs to be managed in the same way that we would with a person with bilateral hearing loss. Consistent use of the audio processor and getting to that consistent use quickly is a really important factor. And managing that expectation that maps need to be progressed and managed, as particularly over those first 6 months. Tinnitus, really interesting topic for people with single-sided deafness. Very strong evidence to show that most people using a cochlear implant for single-sided deafness will experience a reduction in their tinnitus. Relief often occurs instantly once they're wearing their audio processor, and benefits increase with time and consistent audio processor use. So those improvements are both in loudness of the tinnitus and the distress the tinnitus causes. So really great measurement to keep track of that tinnitus measurement. We do see that cochlear implants outperform any other alternative forms of treatment for tinnitus for this population, single-sided deaf. So let's now look at some outcomes for single-sided deaf cochlear implant recipients. We are getting quite a lot of research published in this domain, and it's really exciting to read that adults who have a cochlear implant for single-sided deafness, they are reporting and documenting better speech understanding in noise. They describe it as much easier to follow conversations in a group. They're reporting ease of hearing in busy places. They can recognise where sounds are coming from, and this is really helpful for not only for safety reasons or professional reasons, like the nurse I mentioned in emergency, able to do her job better, but they can, once they can localise to speech, it also makes it easier to hear in noise because they can use all the speech reading cues that all of us naturally use in conversation. We have measurements to document less listening effort and less fatigue from listening, improvements in social interactions, and significant improvements in quality of life. I know one of the topics that people want to know about is with acquired deafness, how long a duration of deafness puts a person out of consideration for a cochlear implant. So here we have this study published in 2013 by Daisy Tavora-Vieira, great researcher in this field in Perth, in Australia. And she identified the longest duration they implanted at that point was 25 years duration of deafness. And after 1 year, that individual had improvements in speech perception level equal to typical hearing. So 25-year duration is not a contraindicator to a cochlear implant for single-sided deafness. In my personal experience, we implanted a woman here where I live in Queensland who had a 60-year duration acquired hearing loss. She was in her 80s. Her other ear has a progressive hearing loss, and it was not going to be a candidate for a cochlear implant. I don't know why. The 60-year duration, she has struggled to get clear speech perception, but she still values the cochlear implant on that side because it's given her improvements in spatial hearing. So what about children? We've got some great literature on outcomes for children. This systematic review I found valuable, published in 2021, demonstrated that children are documenting improvements in speech perception in noise and in quiet, improvements in sound localization. Through their cochlear implant alone, speech perception, so this is streamed speech perception scores, between 30 and 100% in speech perception. What we can see from children is that a shorter duration or acquired children with hearing loss who are acquired are quicker to pick up their skills with the cochlear implant, and they are documenting more improvements in speech and spatial hearing. I wanted to share with you this study that was only published this week. Always good to have something so recent, so current, that documents the longitudinal cochlear implant use in children. So this is from 2 large centres in the United States. The outcome measurement was only looking at audio processor use. And interestingly, the average age of implant here was 7.3 years. They had a mixture of congenital and acquired hearing loss. So you can see here that after 2 years, still pretty good speech processor use, audio processor use after 24 months. The study did identify this point here, the 6-month mark. The wear time at 6 months pretty much establishes the wear time ongoing. So that's your goal, to get good wear time practice in place by 6 months. This is interesting, 7.3 years, average age of implant. I wanted to share with you this information that documents implant age for single-sided deaf children. So children congenitally deaf really varies around the world. So you can see here in Australia where I am, and we have a lot of experience with single-sided deaf cochlear implants in Australia. Children must be implanted under the age of 4. They must receive their cochlear implant under the age of 4. Now, this is in absolute contrast to the United States, where the minimum age for implant is 5. Then we've got parts of Europe where the minimum age is 5, but hey, we'll do them between 1 and 3 years. Japan is about to start cochlear implantation next month. I think it passes through the regulatory process, and it will be minimum age of 5. So huge variability in age of implant for single-sided deaf children. This study also came out very recently, last month, by Lisa Park in the States. So, as I said, minimum age of 5 in the States. But Lisa Park's group did an off-label study where they were implanting children as young as 1. So children with a congenital single-sided deafness from 1. And this study does show that the conclusion was that the younger the children who underwent cochlear implantation, they demonstrated more stable device use, faster speech recognition gains, and a trend towards better spatial hearing. So I think this is a really interesting space to be looking at. And my feeling is that younger is better, like we know from our work with bilaterally deaf children. One of the topics that parents are really interested in is this sound localization. Being able to work out where sounds come from keeps our children safe, It's also a significant benefit in a classroom and in learning environments, because being able to work out where the person is speaking